Now, we have kept the definition of suspected CPA as any patient who has got structural lung disease like fibrocutaneous lesion or fibrobronchiectasis, and who would be presenting with the complaints of cough, sputum production, hemoptysis, or there could be fever or any other constitutional symptoms presenting for a period of more than 12 weeks of duration. And the sample size calculation was taking into consideration the prevalence is 10% and the precision is 5%. So we concluded with a sample size of 138. Next slide. So about the approach and materials, it is as usual like any other observational study. So written informed consent and then recording of all the clinical as well as the demographic details of the patients. Then collection of sputum as well as blood samples for special tests as well as the routine tests, and chest imagings and any other relevant test which might be helpful to carry out the study. Statistical analysis that is supposed to be done with the help of the software IBM SPSS 22 version. Next slide. So now, as I have said that we have started from 1st of April 2025 and the study is still ongoing, and that is why up to now only 35% of the patient recruitment has been completed. And that is why today whatever I am presenting in front of you all, that is just a preliminary result. So 3 observations till now I have come up with. First one is that all patients with structural lung disease or structural lung abnormality do not develop CPA. Second observation is that NPIP, that is non-pharmacological infection prevention practices, like for example using of regular face mask, then secondly is the hand hygiene, and thirdly is the airway hygiene. So this can significantly reduce the development of CPA as well as improve the quality of life of patients suffering from the disease. Observation 3 is that concurrent medical and surgical management can of the severely affected patients can reduce the development of CPA and also stabilize their condition to a great extent. Next slide. So as I have said that it is still ongoing, and these are only the preliminary results, so that is why we cannot conclude, because by the time we complete the study, maybe we might come up with few changes with the results. But up to now, these are the different observations. And this I would like to conclude, and then not boring everyone with too much of talks and all that. So now I would be happy to take up any questions if there may be. Yes, sir, please.
Thank you. I think, how was the diagnosis of aspergillosis made? I see you have a suspected definition, but was it radiological? Did you use any serological testing?
So thank you so very much for the question. Actually, as I have mentioned here, that suspected cases. So initially when the patients come up to us, my first observation is that all patients with a structural lung disease or abnormality do not develop CPA. So we just have a suspicion of such patients and then we go forth with the other things. So clinically, I have said that the presentation I have talked about the presentation of the patients, the different complaints. Then next thing is the radiological images. So these are some clinching things which might, from which we can suspect a patient. But ultimately, to confirm the diagnosis, we definitely go for the serology. And we ask for the serum aspergillus specific IgG test, which is a very confirmatory test. It is 100% specific, and with the help of that, we are definitely diagnosing.